Welcome back, guys. Sam El-Ghazawi, orthopedic sports medicine surgeon here in New York City. So today we're going to talk about Odell Beckham Jr.'s injury during the Super Bowl. All right, so here's the play. You see Odell is coming, tracking the ball. We're looking at his left foot. His left foot hits the ground here, and this is what's called a non-contact pivoting injury. So his leg is going one way, his body is kind of falling into a different direction, and this in our world is called a pivot shift. So the shin bone here is actually going forward or in front of the thigh bone. And you can kind of see it if you look closely. It kind of shifts and pops right back. And he feels it. He can immediately feels that pop likely and grabs his knee. If we look at it from a different angle, so this is kind of the angle where we're looking at it almost from the front side view. You can again see where his foot lands, hits the ground. His momentum's still carrying him one way, and his knee falls into a bit of valgus, or kind of bends inward. And you see that kind of right there. If we kind of go slow, you can kind of see the shin bone shift anteriorly or forward in front of the thigh bone, and then pop right back. And that's kind of that moment that ACL gives way. You know, it's essentially a rope that keeps your knee from shifting back and forth. So, you know, when we're talking about ACL injuries, there's probably some pertinent anatomy that we have to go over. This is a right knee. If we move the kneecap out of the way, there's a few structures here that we're always thinking about, we're always examining when we see patients and athletes in the office. The most obvious one for an ACL injury is the ACL. That's this structure right here, right? So it connects your thigh bone to your shin bone or your femur to your tibia. And it's essentially a rope. It's a rope that keeps your knee from shifting that way, right? The other structures in here, there's your lateral meniscus and your medial meniscus. These are kind of cushions for your knee. And then in the back, you have your ACL, which stands for anterior cruciate ligament. You also have a PCL, stands for posterior cruciate ligament. So if the ACL keeps your knee, your shin bone from going anteriorly, the PCL keeps your shin bone from going posteriorly. That's kind of the way that we name things. We're not too clever in orthopedics. When the ACL tears, again, that's this structure right here. With that non-contact pivoting injury, you can see that that knee wants to slide this way, and that rope, that ACL, is keeping the knee from sliding, or the shin bone from going anteriorly or forward. If there's too much stretch, if there's too much force, that ACL pops, and that knee buckles. So kind of just like in that Odell video, that knee shifted like this and then came back that way. There's other structures that can get injured. If you can imagine, that knee's kind of doing this pivot shift. That lateral meniscus is more common to get torn acutely with an ACL injury, but then also the cartilage can get injured. So these are all things that we're looking for on the MRI or when we're examining patients in the office. So all that being said, what do? There's a lot of different treatment options for ACLs, but if you're a young, active athlete, or if you just want a knee that doesn't buckle or shift on you, you need an ACL. You don't need an ACL to walk in straight lines. You don't need an ACL even to run in straight lines, but any kind of lateral motions just kind of makes sense, right? It prevents that turning, pivoting force. You need an ACL. So what we do is we reconstruct the ACL. There's a few different options on how we reconstruct the ACL. If you're younger, we tend to want to take your own tissues. That's what's called an autograft. We can take your patellar tendon, so that's this tendon right here that connects your kneecap to your shin bone. We take the central part of that patellar tendon and we reconstruct the ACL with that. We can also take part of your quad tendon, so this is your quad tendon coming down and attaching at the top of your kneecap. So we can take a piece of the quad tendon and reconstruct this ligament in here. We also can take hamstring tendons. So you have 3 hamstring tendons that come on the inside of your knee and attach on this side. We can take 1 or 2 of those tendons, loop them over themselves, and then recreate that ligament. If you're older, there is an option for something called an allograft. So that's actually where we take cadaver tissue and reconstruct the ACL with cadaver tissue. And then obviously if you have a meniscus tear, if you have a cartilage injury, that also changes what we're doing. We try to keep the knee as healthy and normal as possible, so repairing those structures at the same time really makes sense and keeps our athletes on the field. You know, the great part about being an orthopedic sports medicine surgeon is that I get to take care of these injuries and I get to see the whole spectrum. I see players when they get injured all the way up to getting them back to their sport of choice that keeps them happy. The troublesome part for Odell's injury is that this is his second time around. So likely what they did is they took part of his patellar tendon with a piece of bone on either side, reconstructed his ACL. Again, there's a lot of different options on what to do. And he retore, right? So now we don't have that option of his patellar tendon anymore. And we have to talk about pros and cons for his quad tendon, his hamstring tendon. Some people would even advocate using the patellar tendon from his other knee. Again, there's risks, there's benefits, there's things that you have to discuss on which graft choice. Beyond that, you know, we have to drill into the bones to reconstruct the ligament. So, you know, there's tunnel issues where we're drilling in, there can be screws, there can be buttons, and it makes it a little bit more complicated when you're doing a revision surgery. Not sure what the reason for Odell's re-tear was. Sometimes it's just bad luck, having that knee in just the wrong position with the wrong forces. But we always look at the tunnels and say, hey, is that a reason why the ACL failed? And we have to deal with those tunnels and figure out if we can use the same tunnels or if we have to stage the procedure, bone graft the tunnels, and then come back and do a second ACL later down the line. So the other thing about when you have a re-tear of an ACL is you start to look at other factors that might be at play. One of the things that has gained some popularity in the orthopedic literature is a new ligament called the ALL. So that ligament kind of lives on the outside of the knee. What we think this ligament does, it actually prevents some of that rotation. And kind of like we talked about before, that non-contact pivoting injury is what really puts that ACL at stress. So if this ligament isn't working, the ALL, there seems to be more rotation. So in revision situations where you've already had an ACL surgery and we're doing it for a second time, a lot of people are advocating doing an ALL reconstruction to add some stability in that motion, in that rotational plane. All right, guys, I hope you learned a little bit about ACL injuries. You know, it's a huge bummer that Odell's having to go through this again. I know some of you out there are probably in the same boat, but it gives us the opportunity to talk about anatomy, the injury pattern, and treatment options. If you have any questions, feel free to reach out. I'm happy to answer your questions and you know, hopefully get you back on the playing field or whatever sport that you're into. And if you have anything that you want me to explain a little bit more or dive into, just leave it in the comments below.